This is our topic today. Anyway, we have two experts to talk about this. I will give a little appetizer for you all in the beginning. What you are going to get in these two expert lectures. What is cancer? As you know, after heart disease, cancer is known to be the second most common cause of death. Cancer is a broad term where some of the body cells grow uncontrollably, disrupting the balance and spread by invading or damaging other parts of the body. The scaring thing is 1 in every 2 men and 1 in every 3 women will be diagnosed of cancer in their lifetime. This is what they think. So all of us might get cancer, but I don't think we have to scare very much. If we detect early, we have a lot of new treatment options. As you all know, I'm just going to tell you what cancer is, right? It is actually uncontrollable proliferation of your cells. Normally our cells doesn't divide uncontrollably. There is a limit. Right? After a certain time, the cell doesn't divide. It divides only up to a point that they want. In cancer, what happens is, as you say, cancer tumor, there is uncontrollable. It divides and it also invades the surrounding tissue. Right? Now, say for example, if we cut ourselves, right, and the cells will divide and it will close the area where we got injured. It doesn't go beyond that. There is a control. But in cancer, there is no control. It goes on proliferating or growing. Right? The important thing is not like normal benign. Now the difference between benign and the cancerous tumors. The cancerous tumors, they metastatize. Right? They can go from one place to another place. Normally, cells doesn't break from their origin and go to another place because they are tied to each other. So, in cancer cells, they can detach themselves and metastasize to organs by epithelial to mesenchyme transformation. There is a cell transformation. From that, they can metastasize from epithelial to mesenchyme transformation. So when that happens, they can detach and go and get implanted somewhere else, and the cancer can grow. So that is the difference between benign tumors and cancer tumors. And the new research say that they can even work as stem cells. So this shows that how transformation can occur and where it can metastasize or where it can spread to other areas in the body. So if you take cancer, there are certain types of cancer, which is hereditary, familial and sporadic, right? So our experts will go through all these in depth. So I'm just going to tell something about cancer, something about chromosomes, what is DNA and what is genes. That will be very important for you all to understand what our experts are going to say. Right? So our cells, we have trillions of cells in our body which contain chromosomes, pairs of chromosomes, which contain our genetic material. The chromosomes are made up of DNA, right? Inside DNA, you have genes, which controls our body. Our entire code is there. If you take this diagram, you can see this is the cell, and you get the nucleus. And inside the nucleus, you get the chromosome. Inside the chromosome, you get this DNA molecule. right? Inside this DNA molecules, you get the genes which control our cells. Each gene has a specific job to do. Right now here, this gentleman is videoing, right? And somebody else is controlling the sound. Like that in our body, these genes have specific function to do. And they do it specifically, right? So, cancer arises from mutation of one of these genes. One of these genes in the nucleus changes. So, it's called a mutation. When it mutates, it changes. It doesn't work the normal way. So, then it can become a cancer, right? Mutated genes that causes cancer called oncogenes. It is thought that several mutations need to occur to give rise to a cancer, right? If our body is unique, even if there are some mutations, it doesn't cause cancer. There are some protective mechanisms in the body, right? So if we take one of our cells, right, you can take it as a car. If you take one of our cells as a car, the car has brakes, accelerator and gases, right? So if our cell is going too fast, our cell has its own protective mechanism where it applies brakes, so it can stop, right? So if it going fast, you can slow the accelerator. So like that the body itself has a lot of controlling mechanisms. So when the gas is empty, the cells can't divide anymore. So what I am saying is that our body has several mechanisms to protect ourselves, right? So basically our body has a brake system. The cells has a brake system. If the car is going too far, it will brake, so it will stop, or the gas will be over, so it will stop. But these genes are called tumor suppressors. So if there is a change in this tumor suppressor gene, then that will go on growing. So that is what that will happen. The one brake system in our cells will not be there. It will be altered, right? So if somebody has a mutation in another set of genes called oncogenes, then you are constantly pressing the gas, right? The car will continue to grow. So the cells will continue to grow. Still, there is one more kind control system, which is gas, right? Once the gas tank is empty, the car cannot go anywhere. So you have a third sort of control. So the third sort of control is that these cells cannot divide ever, right? After some time the cell division stops. As we ages, certain our body organs doesn't grow. So like that, the cancers also, our cells also has a control system. Right? Because after that, there will be cell death, right? There is a limit any cell can divide, right? So this is determined by an enzyme called telomerase. In cancer, they turn on this telomerase and they keep adding telomerase to the end so that they don't stop. I will explain to you that. Now there is these are these telomere particles, right? When in normal time, when it divides, it becomes like this. So these telomeres become absent. So it cannot sort of divide anymore. It stops, right? It stops growth. So that's the normal way that the body controls overgrowth of cells. But in cancer, somehow this is overcome. the cancer cells see that these telomeres are continuously added to the chromosome, they continue growing, right? So therefore there are three major hurdles that a normal cell has to gain to become a cancer cell, right? Need to mature the tumor suppressor gene. There is a gene called tumor suppressor gene in our cells. So they have to mutate, it has to change, right? Then need to mutate the oncogene to become active and have to continuous activation of telomerase. So there are these three steps has to be there for one of our cells to become cancer. So our body has so much of protective mechanism for the cells to prevent them from becoming a cancer cell. So why these things are all important, I will tell you one. And there's another last hurdle, right? That is our immune system. If our body, one of our cells change to some other thing, our immune system will attack them and kill them. You know, now your kidney nobody else can take, right? Unless you give immune suppressor drugs, the body will reject it. If you take a skin from your and put to my skin, it will get rejected. So same way, when a cell is turned to cancer, the body will automatically reject it because our immune system. So there is another system. But the cancer cells convince the immune cells not to kill them. So that is why they grow. That is why our immune system doesn't work. So our immune system doesn't recognize them as new cells. So they convince, don't kill me. You know, I am one of your friends, right? So but Professor Jim Allison now recently not recently, some time back, have invented this secret code, right? And now scientists are able to block these signals, right? In new type of treatment. By doing that, he is able to make the immune cells kill the tumor cells, which made a huge impact. I am just trying to tell that these are the new things that is available in the treatment called immune therapy, right? If somebody has a melanoma, sometimes ago it's a death stage. Now due to immune therapy, they survive, right? And also now we have targeted therapy. Now those days we used to give only chemotherapy, right? Where general activity of cancer cells are suppressed. Now what they do is you give targeted therapy. We detect the cancer you have may be different from the cancer another person has. So what we do is we give target therapy. So we see what is the cancer you have, and then we give each medicine for each different person. So these new things are now available. Our experts will explain to you much more than this. So actually the future is bright, right? We don't have to get scared that we are going to get cancer. We have to detect them early and treat them early. So because if 1 in 3 are going to get cancer, it's something that we might most likely get it. So we can actually treat.
So far you have listened about what is cancer and what are the causes for cancer, how to detect early and how you can avoid even getting the cancer and all is good thing. So now we will go on to see, especially I would like to emphasize more about our local treatment options available in Sri Lanka and all. So first anyway, quickly again I'll just, as an oncologist, we all should be involved in prevention, early detection, treating and cure and care also. Care means palliative care and all. You should not say there's no option for anybody to have it when they come to cancer hospital. Can you hear me? Okay.
Yes.
Yeah. Then cancer incidence, actually the National Cancer Control Program is every year they are making a booklet called Cancer Registry. You all can see it in the web page. You can type it NCCP in the Google and you can get a lot of information is there. There are so many pamphlets, booklets you can download and see, and you can go through all the statistics and know about cancer state in Sri Lanka. This is one of the cancer incidence and mortality data for 2021. This is the latest one I could able to get that. And so, as earlier Dumindu said, in Sri Lanka, around 37,000 new cases we are identifying each year. Around, you say, up to 40,000 even. Sometimes we may not be recording it in the registry. Sometimes we may missing the data and all. So among them, 20,000 and 20,000, 17,000 male and female, like that. So female is a bit high. And every day, 103 new cases we are detecting. So this trend also in rise. When you see this graph from 2005 to 2021, they say rising incidence you can observe. So again, you have to know to prevent or to do more plan any treatment options, whatever the things in Sri Lanka, you have to know what are the common cancers among males and females. If you see males, usually the oropharynx is the more common, then comes the lungs, then colorectal, then comes the esophagus and prostate. First 5 I am telling. But why do you get more oral cancers? Because most of the males are chewing betel chewing and smokeless tobacco chewing and drinking alcohol, smoking, all these together, these oral cancers they are getting. Females, more common is breast, second one thyroid, third one colorectal, then ovary and cervix. Earlier days, earlier statistics if you see, first breast, second cervical cancer, then comes the colorectal and so on. But these last 2-3 years statistics, the thyroid has come up to second position. Why do you think? It's an over-diagnosis, because most of the people, when they say change in their neck, any lump or any small thing changes there, they immediately go and see a ultrasound radiologist and get the ultrasound done. So when they do the ultrasound, they will find a small nodule and that will be put up FNAC, they will do a small needle test and then they will diagnose that as a cancer in the early stage. That's why these 2-3 years the thyroid has come up to the second stage. But the other thing is cervical cancer also, good pap smear testing, early detection, that is pre-cancerous stage we are detecting. And also now only we have started recently the HPV vaccination for school children, 2 doses. That will be reflected later on only, not immediately, because it will take some time to see the results. So then further down it will go, cervical cancer will go further down in the list. So you have to know what are the common cancers among males and females. So this is again the pie chart. You can see males, first oral cancer, second lung, third colorectal, and then esophagus and prostate. Females, breast, thyroid, colorectal, and ovary and cervix. The strange thing is the colorectal is number 3 cancer. It has come up to the third common cancer among male as well as female. Why do you think? It's mostly earlier they have found it in the West, because more obese people, those who eat more fat and not doing exercise and so on. Because our trend also is the same thing, no? If you just watch, just you wait in the Gold Road and just see how many Uber Eats are going. You just see how many Uber Eats are up and down going there and here. If you do a statistics, you will find they are staying at home and ordering for the high-fat diet, and they are eating and not doing any exercise. Even they see the television by remote control, they change the channel. So they are very minimal exercise. So they are becoming obese. So the statistics also showed that a lot of people are obese. Only very small percent people are underweight. That is less than BMI of 18. But most of the people are more than 23, because 20 hours Western setup 25, our one we have to even still reduce the BMI 23 and below. So we have to make it a point to do some exercise. Even during working time, even you may not use the lift, you just climb up and try to do it, because you don't have time. So in the working place, you just you use the steps, staircase, right? Okay. Then comes the leading site among females. The first is breast, and this one you know that really also we have. So this is among children. Children also nowadays around 1,100 like new children are getting diagnosed with new cancers each year. There is mainly the leukemia, hematological malignancy. Then comes the brain tumor. Then comes the other organ tumor like nephroblastoma, hepatoblastoma, like. So this is the more common is hematological and lymphomas, and then brain tumors. So this also earlier mentioned. This is again, you see the trend is more cancers are detected in the old age group people, because old age only these gene issues are coming up, because they can't control the cell divisions. So out of control cell divisions are happening. So above 55 onwards, more number of people are getting cancers, and we are also in the aging population. There are epidemiological transition, so everything is going towards, because we are getting more non-communicable diseases, including cancer. And also you have to remember, cancer, heart disease, diabetes, all that common factors like, for example, less physical activity, obesity, and smoking, alcohol, all play a role for all these things. So if you avoid these risk factors, you will be avoiding all these heart attack and other things and all that. So better avoid not only cancer, you can even reduce the heart attacks and all. So this is also very important graph. But in Sri Lanka, the common death is commonly death is due to the cardiovascular disease and all. But in Western countries, it's due to cancer. But in future, we also will be experiencing cancer death more, because cancer is, you can now and then in your close friends or close family, you will have 1 or 2 person having cancer. Most of the time, if you just think about it, definitely you will have. I am having the same thing, you will also be having, because it's such a common thing. So this also again, now I am going into the treatment things. So in Sri Lanka, we are having a cancer policy. Cancer policy, what they say is another thing we have to be proud of when we go abroad for any cancer conference or anything. When we are presenting, we are very happy to say that our system in Sri Lanka is a very good system, colonial setup, that from a hierarchical model is there, from the Ministry of Health and the national hospitals, teaching hospitals, then base hospital grade 1, B, grade A, B, and then divisional hospitals, maternity home, and the CND like. We are having one robust good system, so that everybody within 2 to 5 kilometers they can access to the free health system and free education. When we say free health, free education, and this sort of hierarchical system is available in, the people can within 5 kilometers they can access a free health system. Everybody thinks that it's actually a wonder of Asia. No? Within this Southeast Asia, we are having a good sort of system, and we are having a good government sector system. But if you see in India, most of the time each doctor will start one private hospital, and there will be so many private hospitals, and only the government hospitals are very few and less facilities, and very poor people are accumulating there and so on. Here not like that. So we should be proud of that system. Similarly, the cancer policy also made in such a way that each province should have one center of excellence, and there should be some other satellite centers within that province in each or 2-3 districts and so on. So here, if you see, there are a northern province in Kelipale, and in the north central province Anuradhapura, and eastern province Batticaloa, and Uva province Badulla, and like that Kandy in the central province, Colombo, Maharagama, and Goa Kharapetiya, and northwestern province like Kurunagala and so on. Like we are having a 9 center of excellence. So in the 9 center of excellence, we have radiotherapy facility at the moment in 7 centers. But some centers we have good linear accelerators, some centers only cohort machine, and 2 centers we are not having. One is Ratnapura province, and other one is in the northwestern province, Kurunagar. So we have to have it very soon. So this is the atom blinking ones where you are having the radiotherapy facility. So this way you can care them in the same province without these patients going from far away to Maharagama and all. They are very feeble people, they can't travel, they will be very painful things, they are having conditions and so on. So they will be very happy staying with their family and getting the treatment nearby their place and so on. Right? Okay. So this is the Maharagama Cancer Hospital, and the newly built one, you would have seen that is called Rasavi Block. This is actually a cost sharing project done by the Iranian counterpart and this Sri Lankan counterpart. One Ahmed people have done it. And then PET CT scan also made it by some general public donation and so on. Similarly, this is actually the earlier, during the wartime, what happened is most of the patients from the north have traveled up to Trincomalee by the ship, by the ICRC ship, and from there they have to come and so on, untold trouble they had that time. Now after everything settled, so now they are having a very good services in Telipala. They are having a separate project, and there is a trail project due to the public funded they walked from south to north and made this trail hospital, and they are doing well. Similarly, in Kandy also there is a new machine recently installed that's called linear accelerator machine. There are two machines there. Similarly in the other places also, Maharagam also they have installed. And so there are facilities are made available everywhere in the provincial level. So you need not to worry much, and this will go on as planned. So the cancer care services in Sri Lanka, you have seen, provided actually state-funded free health system, and main treatment modalities, you all know that one is surgery, then radiotherapy, then chemotherapy, then hormone therapy, monoclonal antibodies, immunotherapy, and palliative care even. So these are the principal main treatment options, but these can be combined or in a sequential manner. Sometimes we may start with surgery from the beginning or start with radiation from the beginning. Sometimes we give chemo first and then go for surgery and then go for radiation, like that. There are so many ways you can treat these patients depending on their stage and all. So whenever the patient is having a cancer, they have to first get whether he or she is having cancer. After the diagnosis, we have to stage how far it has gone, whether still it is in the local place. For example, if it is a breast lump, a small lump, what is the size of the lump, whether the breast lump from the breast cancer, from the breast lump, that cancer cells have gone to the armpit, to the lymph nodes, or from there even it has gone to other organs like lung, liver, or bones and all. All we have to assess it. That's called staging, pre-treatment staging. If it is well localized, early staging, most of the time local treatment we start immediately, like surgery or after surgery radiotherapy, like that. But if it is spread, some people may come in very late stage. This, as earlier Dumindu said, this is the month of October is a month for Breast Cancer Awareness Month. It's dedicated as Breast Cancer Awareness Month. But still, I am sorry to say that even the educated females, one lawyer recently came with full-blown fungating breast cancer. So obviously it is smelling and all. But still she was out of shy. She managed to be with that for some time. And now she has a little bit with the chemo, everything responded and so on. So why you should be so shy to come with such late stage? So you have to try to come with very early, is a small lump level you have to come. Then you will be living like other people, because after treatment. So if you come late and in a time with very much spread, we can't blame people coming with late stage ovarian cancer, because ovary is inside the abdomen where you can't see, because you can't palpate and see, because it will be inside growing, and unless you do a scan you will detect early. But here obviously you can see outside. There is a lump or there is a ulcer, small ulcer. Why you wait till the whole breast changes into a cauliflower-like thing? So these things you should avoid, and everyone should be aware about your breast. And that means you have to palpate and see breast self-examination, on and off you do a scan. Rather than doing for thyroid scan, you have to better do scan for breast, because thyroid, even if it comes a little bit later, they will live long, good treatment options are there, that's all. But both you have to do better. Right, so that is important. So surgery and radiotherapy, you have to remember, it is a local treatment. Then chemotherapy is systemic treatment, but it has a lot of side effects. So if you come late, you are invariably, you should have the chemotherapy. If you come early, most of the time you can avoid getting this chemotherapy. This is a very nasty one. Then other one is hormonal therapy. But that means breast cancer, for example, sometimes estrogen receptor positive, if it is there, so we will give 5 years of hormone treatment against this estrogen, estrogens, anti-estrogen tablets. then monoclonal antibodies. Why we are giving this sort of target treatment is to reduce the side effects, because otherwise what will happen is this chemo and all, it will not only act on the dividing cancer cells, it will act on dividing normal cells like hair cells and bone marrow cells, or even our bowel cells. Wherever wear and tear is happening, the cells will be replaced, that will be continuously dividing, germ cells, so the ovary and testicles and so on. So in those system, those parts also will be affected. That's why we are having hair loss, we are getting white cell dropping, and we are getting loose motions and all, because our bowel getting affected when the bowel wall inside. So then they won't absorb, the non-absorbed part will go as diarrhea, and the skin will be changed and all. So you can avoid that. And immunotherapy is, again I will tell about that, because now it is a very hot topic. Most of the places, most of the cancers are thought as a hot tumor. Hot tumor means it will act on, immune will act, because each one of us will be having few cancer cells definitely, but that will be kept under surveillance by our immune system. Otherwise what will happen, every day when you go outside under the sun, your cells will be getting, your DNA will be getting deranged and your DNA will be hit, but immediately DNA repair genes will act on it, and immediately the DNA repair enzymes will act on it and correct it. The similar way, some small amount of cancer cells will be there, but it is not producing a lump or anything in our body. Even after our treatment cannot completely get rid of cancer cells. It will be given to the immune system to keep under surveillance, so not to come up again like that. So immune system is very important thing in our body to keep our cancer cells under control, under check and all. So, but that's why that sort of things are used. Now immunotherapies are being very much popular, and everywhere immunotherapies, but only thing is cost. So this is again in the treatment options I have put as a department wise, like radiotherapy, radiation oncology department, medical oncology department, surgical oncology, gynae oncology, pediatric oncology. Because earlier days when I went into the cancer hospital in 1999, we have started treating pediatric, hematological malignancy and all the malignancies. Later on, the pediatric malignancies, pediatric population were treated separately by pediatric oncologists. Later on, hematological, that means blood cancer and lymphomas, and those are now different group of people. They are called hemato-oncologists. Others are clinical oncologists who are dealing with the rest of the cancers and all. Time to come, the people will choose 2-3 sites and specialize on that. And because our population, the oncologist number is not much enough, and many have gone abroad and stayed there. They are not returning now due to this crisis situation and all. So these are some challenges we are going to face. Then if you see the cancer patient, he may be in any place, on diagnosis time. That is diagnosis, I earlier said that after diagnosis you have to stage it, maybe in the early stage. So at that time we may offer curative treatment for some group of people. Some group of people who come in very late stage, we may have to give only the palliative option until the death. And so we have to offer something not to suffer and maintain their quality of life till they die. Even after death, sometimes younger people having this sort of disseminated cancer, after death there may be grief and all you have to, bereavement, everything you have to tackle it. That's even beyond death you have to tackle that family and so on. But if they come in early stage, you can go ahead with the curative intention, and you can cure most of the time. That is also now with the newer treatment options available and better technologically driven computer-based planning in radiotherapy, we can offer a good treatment with less side effects. Because earlier days with the cobalt machine, we have given a bigger area of radiation treatment. Now you can very nicely modify the treatment in such a way that cancer cells will get higher dose and the nearby organ at risk will have a smaller dose, so that you won't get much side effects and all. So this is the way that you have to keep them under surveillance at least 5 years. But for breast cancer, we sometimes go up to 10 years, because if they are having estrogen positive, we give hormone treatment till 10 years. So these are in the NCCP, I said, National Cancer Control Program webpage. You have a lot of materials available for prevention part, family leaflets, or you can download and share with your friends, because everybody has to, it's in everybody's business, cancer control. Because not only we talk to you, you can tell to a few more people about this and how you can prevent this and all. So you can disseminate more knowledge amongst your peer groups and all. So there are similarly the cancer treatment guidelines also available for breast cancer and cervical cancer, and pain management guidelines and palliative care policy draft. Now is a policy document. Everything is available. Every 5 years they review it and put it there. So you just go through National Cancer Control Program in the Google and do some research on that. Then you will know more knowledge on that. Then when a patient comes, not only the managing the disease, the patient may be having a lot of things. So you have to break the bad news. How to break the bad news, the communication skills, how doctors are now being trained on that, because they will get very upset, no? Then you have to slowly tell about that. Even during the investigation time, you have to tell what we are doing, and slowly then they will understand what it is and so on. And not only that, physical, psychological, and other social issues. They may be coming from far away. You may refer to the nearby hospitals where the same facilities may be available. You have to say that some only you have to come to Maharagama, or the most of the people are coming to Maharagama Cancer Hospital thinking that it's the only tertiary hospital for cancer. Only few more facilities are only available here, like radioactive iodine, brachytherapy machines. These are the additional thing we are having. Other than that, in Kandy or Galle or Jaffna, the same sort of facilities are there. You have to convince them so that they will go back to the nearby hospital and so on. And then the spiritual aspects, practical aspects, so that a lot of people have to involve, and end of life care, loss, after loss grief, everything you have to tackle. There should be, because now palliative care also coming up as a big thing, because everywhere this comes up. I will tell about later. So then, for example, I am telling this is about cervical cancer, cancer of the womb, neck of the womb. It's called cervix, cervix, cancer of the cervix. So in 1999, they have started with chemo radiation, with cisplatin and radiotherapy. Then slowly every year the treatment options were changing with the change of chemotherapy. Then vascular endothelial growth factor inhibitor, that is called bevacizumab, included. That has got more advantage. Like a lot of randomized clinical trials are happening in each cancer. This is just put a one cancer here. Then now, after 1999, 2024, the same thing of 1999, they have added one immunotherapy. Only that one they have added. Now 1/3 betterment is happening. That means 33% more survival is noted. That's called pembrolizumab, 2 to 3 week relief first, then continuously also maintenance dose also we are giving, but expensive, but still locally advanced cancer patients it's worthwhile giving. That's a recent trial out in 2024. This is the latest update and so on. Then this is also again the radiotherapy from 1999 to up to now. There are so many technologically advanced status is maintained, because like earlier cobalt only. This is the first one, is a one stamp in Canada, because Canada they have produced the cobalt machine. Then stamp was released on in the to shop this cobalt machine. This is a very outdated machine. But now linear accelerator, cyberknife, and proton treatment all are there. So very advanced. That means very specifically giving treatment to the that particular cancer area is possible. So then brachytherapy also, earlier 2D brachytherapy, then 3D brachytherapy, then image guided brachytherapy like MRI guided and all. So when you go on with advancing with the technology, your overall survival also more, because when you are going to advance, you can give more dose to the tumor area. So treatment of ovary, for example, I am telling earlier I told about the cervix. Now just think about the ovarian cancer. Before 1978, there are few options that time available. Some nitrogen mustard, melphalan, and surgery radiotherapy. this nitrogen mustard and all, you have to remember, after Second World War, that they have used some chemicals also that time. That similar thing, they observed the side effect, then they found it may work to the cancer, and like that they have introduced to the cancer treatment. Similar way that surgery, radiotherapy, or in 19 not only, that started with that. So then after 1970, so many newer drugs have been introduced in addition to surgery, and some newer molecules and monoclonal antibodies also introduced. This also again for a cancer of the ovarian cancer, even there is a poor prognosis if they come in stage 3 or 4. But still we can offer so many options available. These are the advancement from 1978 to 2018 I have put it. So how much trials have been gone on, they have made so many clinical trials and they found these things are better like, but this also costs a lot. But still the government is providing most of the things. So this is again this ovarian cancer, how they have been controlled. With the first chemotherapy or after surgery or something, there will be progression-free, PFS means progression-free survival, 18 months life. After that you see 10.2 months second line treatment, then 6.4 months, then 5.6 months. That progression-free survival is shortening and shortening. So after that finally they will die. That the cross is made because this in the western, this one, they are dying, that symbol is given. So these sort of things are happening. So again, that team I told about the immunotherapy, not all are hot tumors. For example, cervical cancer, for example, that immune, how many percentage strong immune immunotherapy driven part and moderate part 52% and very low potential 11%, like that. And other thing is HPV vaccination, because human papilloma virus is one of the cause for cervical cancer. So HPV related things also, immune dynamics are changed. So they are having more immunotherapy can control these diseases. So how the immunotherapy works? For example, it's a T cell mediated immune treatment. For example, tumor and the T cells, the receptors, when they combine it, that tumor cells will be damaged and it will die off. But there are some masking effect. Tumor is also having PDL1 program, death ligand 1, and the T cell is having PD1, and if both of them are combining, that killing won't happen. So tumor also more smart enough to make this sort of arrangement to prevent the killing from T cells. So how the tumor cells are trying to mask or trying to prevent the immune mechanism killing, that the new scientists have found some checkpoint inhibitors that will go and block the tumor cells, that ligand part, as well as the T cells ligand part. So there's the tumor cell can't now mask. That way only the immunotherapy works. That means when the tumor cell is trying to prevent the T cell killing them, so by some other attachment, for example, there are two attachments. If frequently the other masking attachment is there, the other killing attachment won't function. So now that the drugs are there to prevent the masking attachment, where in the tumor cells also they send one place and the T cells also one place, then that place it will go and block it, so that masking attachment won't happen. So tumor cell will some or other, the T cell will some or other kill the tumor cell. Like that the immunotherapy works. So there are so many immunotherapy names are there, that pembrolizumab, nivolumab, and so on. That is PDL1 inhibitor or PD inhibitor, like that. And also bone marrow transplant, also another one for treatment options available for hematological malignancies. There are two types of bone marrow transplant, autologous and allogenic. Autologous means from the same person you can get the cells and keep it, other cancer cells, and give the stem cells back. That is called autologous. Some places you have to have allogenic bone marrow transplant, that is from their siblings or any other matched person, or related or unrelated matched way. You have to match a lot of HLA antigens and so many things are there. So in 1998, 1999, I have to say Dr. R.S. Jeyakumaran has started this as an autologous bone marrow transplant in a small scale, but now it has boomed up and there are so many bone marrow transplantations, autologous things are happening in Maharagama. But it is one Australian hospital is supporting for this training and all this, and it's very well conducted. Slowly it is being done. So it is a very good development in Maharagama Cancer Hospital. Then other thing is Sri Lanka Cancer Research Group is there for local treatment, how to do those audits as well as the trials and all. Even we have done 2-3 international trials as a part of the trial, mytokine trial and some other trastuzumab in the Herceptin trial in the female breast cancer and so on. So we are having a clinical trial unit in Maharagama. And we are having a college for Sri Lanka College of Oncologists, so professional body, where we do discuss about the newer treatment options with our trainees as well as our colleagues and all. And Sri Lanka Journal of Cancer is being published twice yearly and so on. So this is again for the hospices. So I told about palliative care. Palliative care means just symptom relieving. So you should not say we have offered all the treatment, now we can't offer anything like to anybody with cancer. You have to offer something when they come with suffering or any pain or shortness of breath, breathlessness, or any sometimes they will have frequent filling of abdomen with fluid and all. You may have to remove that, and sometimes they may not be able to swallow, so you may have to put a stenting and or any tubing sometimes through the nasal tube, nasogastric tube insertion. Some people may not like. In that case, you have to put PEG tube in the abdomen, so it will be hidden by under the shirt or something. So they may, because they prefer to sort of things in the socialization with the NG tube, they may not like, no. So sometimes I will say some people are having fungating. I will show that picture, fungating any ulcer in the face and all. One lady asked that when she dies, she has to have a covered up face and all. That one we have some other talked to the surgeon and did that. I will show the picture later. So similarly, there are hospices around cancer units. This is one of the hospice that is Sri Lanka Cancer Society is running, Shanda Sevana Hospice near Maharagama Cancer Hospital. Well, and you can accommodate many patients there. And this is again Sri Lanka Palliative Care Association is having Sahana Sevana Cancer Hospice, and in Hanwala that is Satya Baba's Cancer Hospice in the Down, and then in Jaffna near Chumnagam, Kane has a Cancer Hospice is there, and in Anuradhapura Cancer Care Hospice is there, and Palliative Care Center in TH Karapatiya, there is an oncosurgeon, Dr. Oncosurgeon is running that mainly. So Krishanda Pereira, so he's doing this lot of work on that. And they say another one, Institute of Palliative Medicine, that is in the Martha. So then recently we had a hospice alliance. I mean every hospice have been joined together and doing a lot of good work for that. And many people may not be knowing that most of the time if you are having any your birthdays or any death anniversaries or anything, you can share some money to that hospices where they will provide food and other care and so on. That is a very good way of thinking. And then this is some play therapy for children in hospital. And the one important thing is Intra Cancer Trust. They are developing quite a lot because like in West, there are so many Macmillan and other things are there. Similarly, Intra Cancer Trust is very dedicatedly, they are having volunteers, they are doing this weeks and all. So it is a very great help. And for pediatrics, they are having a separate hospice. So earlier Minister, you know, the Karajasuriya's daughters, the Indra, who succumbed to breast cancer, and following that her sister is dedicatedly working there, Dr. Lanka and so on. So you all can visit these hospices. Actually you will feel and you will have some very good touch with our cancer patients if you see these hospices where the patients who are in late stages are there. And then these are the just put up all these together. So there are so many things happening as a supportive treatment and so on. And other thing is, this is also important graph, because if you see the morphine consumption, depending on the number of morphine consumption, the amount of morphine consumption, you can say how good the palliative care is. For example, in Austria and all, per capita 80 milligrams they are using, but in Sri Lanka, India, everywhere very minimum. That means palliative care development is very slowly only happening. So we have to increase that means pain relief is not enough. Like these are the indicator. The morphine use in a country is an indicator of palliative care in a country. So this is again the WHO region of Southeast Asian region. When you see one is nearly 0.3872, then 1.21 milligram per capita in 2015. But Bhutan is getting more, and then Bangladesh, India, very low level only they are saying. So this again, this is the one I told this particular lady actually when I was in Jaffna, this lady asked, after 6 months only she passed away, but she wanted to some more other cover up this because it may smell and during funeral time and so on. Like, so then this was covered up very nicely, and she was very happy after that. So this exposed wound with they have to cover up and smell and everything. So some of the oncosurgeon helped for that. So it's very good quality, that she wanted. So then again, some people say that do not resuscitate and so on. That's why this also we have to communicate very well for cancer patients when they come to private sector. They will first very enthusiastically they will think that they have to go for treatment with the full-blown treatment with up to ventilation and so on. But sometimes they may not survive long. Prognosis, everything you have to explain to the patient. Otherwise, the patient has to spend quite a lot of money and so on. So after putting into the ICU with a machine and all, each day there will be more than 1 lakh and so on. So the doctor's duty to tell about the consequences and all that, right? Okay. So this particular gentleman has put a tattoo on this one. Do not resuscitate, because even if he dies, don't resuscitate or something like that. This was appeared in a paper. So I don't have a death wish, but I just don't want to be kept alive in pain, they are saying. So do not resuscitation also one of the things we have to convey, but blanketly you should not tell to everything like cancer patient, don't. If you are diagnosed with a cancer patient, it is not straight away you should not say that everybody should be do not resuscitate. Some are reversible things are there, like infection, cardiac arrhythmias, aspiration, pneumonia. Sometimes people may be having head and neck cancer, while drinking something they may aspirate and things may go into the lungs. Following that they may have chesty and a lot of cough and fever and so on. You have to treat them properly, those things. But you should not neglect thinking under the cover of do not resuscitation. So you have to be very clear on that, to whom you have to say do not resuscitation and to whom you have to say not to ventilate and all those things we are getting in a clear, after clearly discussing with the informed consent only you have to do that. Another thing is challenges in treating cancer in Sri Lanka particularly. I just to mention few slides. That is most things to be important, because we are not producing any cancer drugs. We are depending on from India or Bangladesh or like that, or in West, something like that. So, but the other thing is some counterfeit products, that is similar products are even being sent as a placebo things also they are sending as it's a false one. So you have to be very careful. NMRA registration is important, and we are not having a lab to check that. We have to send to somewhere else or in Singapore and so on to check, but it's a cost thing, but still you have to do that. Almost all drugs are from overseas, but during the foreign exchange issues we had a lot of issues. But in many diagnostics, even FTG glucose for PET scan we are getting from India, that is being brought by flight, immediately it's being used because it's a short T-half. You can't keep that radioactive material for tomorrow or day after tomorrow. Today, if that comes to the Hatnayaka, immediately they have to bring it, and the patient should be ready, and quickly they have to inject and do the scan. That's the way they are doing. And biomolecular markers, most of the tissue diagnosis we don't have that, so we have to send those things to India. And Linux parts we are not having, and brachytherapy and radioactive iodine. Radioactive iodine also we are getting from foreign countries, from some other place. So these are all costs and all. And the other problem is when we are doing that, our middle person is getting more money. When they are sending, the India, this test may be very cheap, but they got very high price. This should be monitored. somebody has to monitor, or the government has to do this sort of testing by reducing this price, maybe 3, 4, 5 times. There's the middleman's issues, no? Like for example, in the egg issue, you would have seen 10 rupees one middleman is taking for per egg. Similarly, there's here also the same thing is happening. So financial toxicity is other problem is price variation, local market price and tender price, because tender price is different, local market price is different, and because of India, if you go directly and purchase the same bun, you can get it for 1/6, something like that. Fair pricing should be there. Somebody has to monitor these things. And local market price versus price in abroad, and NMR registration, competition and price reductions are there. So during the crisis time, the Sri Lanka College of Oncologists, as an advisory body to the ministry, we gave a list of essential drugs. Because that time I was the president of the SLCO. The problem is, that time why we wanted to this is because some public misunderstood that the college is blocking the high-end drugs here. Why we wanted these essential drugs to be there during that crisis time is, because if you don't give that list, what the people will think is even the ministry or somewhere, some person will influence to get the high-end, high-priced drugs freely available here. Whereas this essential 90% which will be covering all the treatment options will not be there. So what we wanted is, we said we didn't wanted to say that, we didn't tell that not to bring those things. We said this essential drugs should be there all the time with good buffer stock, so that we will be able to treat the patients 90% of the time. So only 10% only the other things are needed. But we ensured that all the essential drugs are coming to Sri Lanka, like that. That worked well, and then this is available all the time and so on. Common cancers were well treated during that time, because WHO also, World Health Organization also has made some essential drug list for the poor countries' benefit, because poor people should not be affected, because corruption and everything comes with high-end, high-price drugs and all, because that can be, margin is high, and people will give more commission and all that are there. So I am telling the truth here. That's why we wanted to put this down. And the per capita, our income and all considered, and did that. Then these are the list that we put it to the ministry. These are essential drugs, should be available all the time in all the cancer hospitals in Sri Lanka. This worked well. And other challenge we faced it during the COVID time. Lot of trouble came in, because cancer patients are more vulnerable to COVID infection, but still we didn't neglect the patients. We have used it with good precaution, and we made a lot of guidelines to make the treatment going on well, and short course treatment were offered that time. That worked well. But in West, most of the time more negligence were observed. So these are the things that we made it as a team. So, and telephone calls, telephone access, and posting the tablets and all were done during that time. So our wish is, finally, we need to get essential cancer medicine on priority. Everybody has to have, Sri Lanka should have essential drugs for treatment, and improve the radiotherapy facility on all provinces, because 2 provinces are not having the facility. But by making the essential cancer drug list, we have saved quite a lot of money that can be diverted to radiotherapy facility and all. And coordinate with all the donors. When the donors are coming, it should be very transparent. And this should be, we have during that crisis time, government in India donated, Sri Lanka cricket team donated, and Direct Relief USA, they also helped a lot. And donors from some college like Sanath College, they did a very good job in Australia, from Australia. So we need to work together genuinely to have a cost-effective management of cancer patients in a transparent and a very genuine manner, so that every cent will be spent to a cause. Okay. So these are some time, that time these sort of articles came up, oncologists concerned over cancer drugs availability, and all these over cancer drug purchases, and so what things we made it like that time. These are some other things in the international papers, the real world efficacy of safe of low dose immunotherapy, because when the newer things are coming up in the West with the immunotherapy, India made a good thing, like good initiative. For example, head and neck cancer, where they have used, for when the Western people are using 240 milligram of immunotherapy, India used only 20 milligram. And they did a phase 3 trial and it showed a benefit. And we are also using the 20 milligram. That also very expensive, but still it is far less than the 240 milligram and so on. So we are trying that sort of low dose or ultra low dose immunotherapy in our settings also to give something to the cancer patients. So this is again in the National Cancer Control Program. You can see that we can win the cancer. So we together, everybody together only you can do that. So alone can't. If together you can go far. No? Alone you can go fast only, right? Okay. So you have to think to go far, right? Thank you very much. So any questions you can ask. Thanks.